and concerned that there may be a virus circulating in one community greater than it is in others?
No, not that. The last statement that there isn't an indication that there is necessarily more virus in one community versus another, unless you might say that based on the fact that we have identified cases here on Oahu as well as Maui that seem to have no connection to travel, so they in themselves represent community-associated transmission. They're a concern because it does indicate that somehow a limited transmission is occurring. But as Dr. Anderson said, we're not seeing widespread transmission yet. So we interpret it as there's still opportunity, there's still a chance to make a difference. And to what Senator Moriwaki was earlier saying, to stronger messaging regarding to emphasize the need for social distancing among our population to the extent possible. If we can be successful, then those indications of limited local transmission can end abruptly, very quickly. But if we continue as we are and we have certain individuals in our community still, not abiding by the recommendations, by the measures that have been, put in place by our governor and mayors, then we will continue to see that transmission occurring.
Another question that I have is, I'm a little concerned about your comments about doctors closing shops. I'm really not sure where I'm going with this question, but, is there any outreach by the Department of Health to make sure that doctors in our hospitals or private doctors have access to information? Because I think some of the questions that we're getting are actually from doctors that don't seem to maybe fully understand. So maybe like even about PPEs, their personal equipment, that maybe you may be telling the hospitals, but the hospitals are not getting the information down to their doctors.
Yeah, remember, these aren't doctors necessarily in the hospitals that we're talking about. Many private practitioners are independent or in small clinics that you wouldn't consider part of the hospital system. Candidly, this is an issue that's been recently brought to our attention more anecdotally than anything else. What we're hoping to do is be able to meet with primary care providers and others and find out why are the physicians closing the doors? Is it because of lack of protective equipment, lack of training? How can we support them? They're so important in our community. How can we help them? It may just be that they're ready for retirement and they just thought this is a good time to retire, which of course is something that we can't do anything about. But if there's something we can do to help them and support them, either in providing equipment or training, we're looking to do that. We haven't engaged in those discussions yet. Actually, we just had these discussions the last couple of days as it was brought to our attention. So we're looking for ways we can better support our physicians.
We are hearing from some that it is about the PPEs, that they're having trouble ordering PPEs because remember, these are single providers. When they put in an order versus a hospital system putting in an order or a clinic putting in an order, I've heard from some clinicians saying that they try to put in an order and they're being told by companies, well, you've never placed an order with us, or you haven't placed one in the last 3 months, so we're not prioritizing you over this other facility. And there's global demand. So I think it is to a certain extent the PPE issue, because in terms of guidance to providers, we have a healthcare website specifically for healthcare providers. So we're posting the medical advisories so that just in case you're a provider out there that for some reason isn't on our directory list or on the hospital list or whatnot, so that they can even just go online and get it. But we recognize that more needs to happen because there are still some providers out there that for whatever reason aren't associated with a hospital system. Most providers, if you can imagine, they need to have some sort of privilege at some hospitals to be able to admit patients, right, in case your patient gets sick. But there are still some providers who don't have that relationship with the hospital system, and those are the ones that we're needing to try and figure out how to have a better connection with.
I have authorized Hilton. We actually give the hospitals some substantial amount of money every year to build up a cache of emergency medical supplies for their hospital, anticipating it, not necessarily events like this, but at least anticipating they may need them in the event of emergencies. They're typically been provided for. They were gathered to be supportive of the hospitals, and what I've mentioned to Hilton is and authorized is that if a private provider does need protective equipment, that we would allow them access to that supply. Of course, there's a limited supply, and doling it out, but we don't want them to compromise the equipment and supplies that are available to the hospitals. But I believe there are some efforts being made now to reach out to the private providers and to let the private providers know that there may be some additional equipment and supplies available through the hospitals. Again, the Healthcare Association of Hawaii is coordinating that, and we're trying to support them. If that's the need, we can hopefully get them the essential equipment that they need to maintain their operations. So,
Wouldn't it make better sense, Dr. Anderson, to have those private providers that aren't used to doing these kinds of screenings send those patients, to like Queen's Emergency or others that are already doing it, and they have the PPEs so that, they're not...
That's exactly right. That was the whole purpose of the testing sites.
Right. So I'm not sure why they don't have that message out there yet, and I think that's really important because they should be able to, over the phone, say, I can give you something and send it directly to wherever they're sending their patient to.
Yeah, most are referring patients appropriately. I just brought it out because it has come to us anecdotally that people are calling the doctors that they've seen for years and only gotten an answering machine, and haven't been able to get through to them, and only to find out that they've stopped seeing patients. So it is an issue. I honestly don't know how big an issue it might be, but I thought I'd mention it while we were talking because it was not something we anticipated initially, but we are hoping that people will be referred to hospitals or to other providers for whatever care they need, and that everyone will get support they need going forward. So we'll try to figure out ways to reach out to them and find out what they need, and if we can help them, we'll help them. If not, we'll be sure that they get referred to appropriate individuals who can.
There are changes happening in the healthcare practices as well as the dental practices, and that the recommendations have been made from CDC as well as us to consider postponing routine appointments, well appointments, just to sort of limit their exposure and their need for PPEs or other kinds of materials and such, and protect them, frankly, right? So the other thing is to realize that PPEs aren't just needed for COVID-19, but for other kinds of illnesses. And so, you need, or even just procedures in general, right? And so to not have that for just the many other things is very concerning for them. So that's limiting their, so there are any number of reasons and issues. But, Hawaii is unique in that we have so many solo private providers, and we need to figure out how to better resource them.
Thank you. I had one last question, and then I'll check with the other senators. Is that a question that was asked of me to ask you was if you could elaborate on your methods of contact investigation. So once you find someone who is...
Right. It can be lengthy, I know. Once we identify a person, we immediately we make contact with the healthcare provider to get as much information from the medical chart and from the provider themselves, as well as then contact the person and to try and interview the person to get all kinds of information, their demographics, as well as especially, walking through with them who have you been in close contact, and, we describe that close contact, meaning especially face-to-face. We want to know their symptoms. How long have you been symptomatic? How long the cough, fever, every aspect of that. So we get a full picture and then enter that information into our database. The contact, if they can generate for us a contact list, then we want contact information, how to contact their contacts. And then we do the same thing with them in terms of, okay, talk to them. You've been exposed to so-and-so, and we understand that you saw them them on this date. Can you verify? And just going through with them and verifying, was it a really prolonged close contact, or was it just in passing, as Dr. Anderson said, 15 feet away, or, you just happen to see each other, say hi, bye in 5 minutes. Depending upon what they tell us, what they describe to us, then we can categorize, okay, are you no risk, low risk, medium risk, high risk? Then the next step is, if you're medium or high risk, you obviously need to stay home. And then high risk, absolutely quarantine. And medium risk, we're monitoring actively with you, self-monitor. It's not this absolute, keep away from everyone kind of thing. Low risk, no risk, it's really just self-monitor, making sure they have the education, know that they should seek help if they need it. So you can imagine, if someone has been very active, as certain people, as you probably know, have been very active despite being sick, it can be very problematic in that suddenly, your close contacts can be, for some people, it's only 2 people, they're going to work, they come home, and they're only in their household, and their family is the ones that we're looking at. That's most people, probably, for the most part. Other people, it's 10 people, close contact. Other people, we've had a few, it's up to 100 people that this is why this is the challenges of entering all that data and looking at it, because when we're monitoring those medium and high risk contacts for a reason, they could be incubating virus. At the point they start to have symptoms, then we're arranging to make sure they get tested, right? Some of them are coming back negative. A couple of them now are coming back positive. Then it starts all over again and making, hopefully we caught them before. Most of them, they've been in quarantine, so it's not an issue now. We don't have to go through their contacts. But occasionally we find someone that it's just a day after, and then, they're already showing symptoms, or even maybe by the time we're notified about someone, we find they're a close contact and they're already having symptoms. Now we have to start an investigation with them all over again. So each one is like a node point that can blossom to another node point and another node point, and each one requires intensive interview, intensive data gathering, data entry, and once we can get that data entered, then we can do the analysis.
So for all of those people that you then follow up and investigate, say 10 or the 100, if they become symptomatic, do they contact you? They contact...
If we're monitoring them...
Is that what you're giving them, instructions, right, that they contact you?
Exactly. So if they're in quarantine or in that self-monitoring, active monitoring with us, then we are monitoring with them, and they know to contact us. With the low to no risk, we're telling them, talk to your healthcare provider, and they'll go through. So that medium and high risk, though, as I said, we know if they notify us that they're symptomatic, then we're automatically making arrangements to get them tested, because of the fact that we've identified them in that medium to high risk group. So they're more likely to potentially be infected, and we want to identify that quickly.
Thank you. Senators, are there further questions? Did we lose our senators online?
Senator De La Cruz is online.
Senator De La Cruz.
I had a question which was asking if the Department of Health was doing any antibody testing.
Not at this time, because there is no approved test by the FDA or CDC, so we are waiting. That's something definitely down the line. We hope there will be some sort of serological assay, but that would be later on down the line. That's not a test that's actually useful for it to diagnose an acute infection at the time. It's only useful after the fact, later on down the line.
Let me ask Dr. Desmond to answer that question. We don't often have Dr. Desmond here to explain, and he tends to be very clear and concise in his explanations of issues like that. So if you could answer the question.
Sure. The diagnostic testing that we've been doing is to look for the virus itself in the patient specimens. And so if we find the virus, we know the patient has the infection. So the new approach that's just becoming available is antibody tests. So we all know that when we get an infection, we develop antibodies, and then that's the antibodies help prevent us from getting the same infection again. It can take 1 to 3 weeks for antibodies to develop. So if you go to the doctor and you're sick, and the doctor does an antibody test, you might not have any antibody yet. It might not develop for up to 20 days after the infection. So you're sick, you've got the virus, but the antibody test is negative. That's what we call a false negative. The other problem with antibody testing is if you have a COVID-19 disease and you recover and you're better, or you're not infectious anymore, your antibody test will still be positive. So that's a false positive result. And the other type of issue which has not been really fully studied with these antibody tests is that there's a broad range of coronaviruses, which we call seasonal coronaviruses, which we've all had. If you've had a common cold, it's one of the most common causes of common colds. And the manufacturers of the antibody tests have not really fully evaluated what's the cross-reaction. If you've got an antibody in that test, maybe it's really an antibody to one of these garden variety common cold coronaviruses you've had in the past. So we find no place for it in diagnosis. I think that, as Dr. Park mentioned, as a sort of an after-the-fact thing, we want to see how broadly the infection has spread. If we have a very specific antibody test, we can do that as sort of an after-the-fact analysis.
When the dust settles from this, it would be very interesting to do antibody surveys or tests of the general population to see how many people were really infected over time, because your antibodies will persist over years possibly, which is the case with most viruses. So we will be able to then learn much more about the disease and how extensively it was transmitted after the fact. But as Dr. Bisman points out, there are no approved antibody tests, first of all. So if we were to try that today, I wouldn't really depend on the results. We may be just picking up other coronaviruses that are out there instead of COVID-19, which is what our interest is. But at some point, hopefully they'll have an approved antibody test, and it would be very interesting to go and do some surveys in Hawaii or parts of Hawaii to see how extensively the virus was circulating. And that may be, looking back over a year, and if this thing's with us in a couple of years, it might be very useful to know that information as we continue to deal with the problem. So, we have a lot to learn about it, and I think there's a place for antibody testing, but it's not going to help us immediately in dealing with this issue.
One more question. You had mentioned the other day that you had just learned that there was this self-administered, and we talked earlier with Dr. Char about this and whether it was effective or not, or how difficult it was and how effective it would be. But if we're looking at numbers, that would be a way of getting more self-administered tests. But do you have an opinion on that?
Do you know anything about this test?
You mentioned it.
Well, it is accepted by the FDA to test nasal swabs, so the patient could just conceivably swab their own nose, or perhaps more sensitive would be a nasoturbinate swab. So that's where you push the swab in a little further to the nasoturbinate bones.
That's what he did.
But not as bad as that nasopharyngeal where you go all the way to the back of the throat. So those are accepted by the FDA. That occurred on Wednesday. The FDA announced that those swabs were accepted for testing. We're still digesting that information and trying to figure out whether that has a place.
But the results still have to be tested through the normal testing procedures, don't they? Or do they have
That's right. So if the patient tests, the potential advantage here is that with collection of a nasopharyngeal swab by a healthcare worker, they're going to be wearing personal protective equipment, and they're going to be consuming and competing with healthcare workers who are in the hospital taking care of sick patients. And conceivably, if patients are collecting their own specimen, they wouldn't be consuming any PPE. But I don't know. I just polled the private sector laboratories just today, and they don't have plans. They don't have immediate plans to be testing these self-collected nasal swabs.
A fascinating discussion there by Dr. Desmond with the Department of Health. We'll be sure to bring you all the details. He was going into when we may or may not have antibody testing. That's the blood testing to see if you've maybe had it and already resolved it in the past. Not yet FDA approved, but that could be a very fascinating look back when that's ready. And of course, he addressed at the end those self-administered tests. Those are, as of Wednesday, FDA approved. It was where you would do that swab at home. But he said he does not know of any local labs labs here or her local physicians who are taking them in to go ahead and to give the results from them. So pending how any self-administered testing may or may not roll out in the state.